From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to JAMA Clinical Reviews. Thanks for joining us. I'm Ann Cappola, Senior Editor at JAMA, Professor of Medicine at the Perelman School of Medicine at the University of Pennsylvania, and Director of the Penn Medical Communication Research Institute. Joining me today is Dr. Johannes Laferton, who is Professor at the Institute for Mental Health and Behavioral Medicine and the Department of Medicine at Health and Medical University in Potsdam, Germany. We will be discussing his piece from JAMA's Communicating Medicine series titled Improving Patients' Treatment Expectations. Welcome, Johannes.
Thank you, Anne. It's a pleasure to be here.
Let's start out with the underlying premise of the article. Why do patients' treatment expectations matter?
Yes, so we have a pretty good evidence base that patients' expectations are linked to health outcomes in various forms of medical conditions or medical treatments. So patients with positive expectations tend, on average, to have better treatment outcomes. On the other hand, patients with negative expectations tend, on average, to have worse treatment outcomes or tend to have higher rates of adverse events. And that's why we recommend to talk about patients' expectations in clinical care.
All right, so let's see what we can do and what we can learn about how to improve those treatment expectations. You provide 4 recommendations for evidence-based communication strategies about patients' treatment expectations. Let's go through them one by one. Your first recommendation is explore treatment expectations and experiences. How do you recommend that clinicians do that?
Yeah. So that's simple. Just plainly ask them about their expectations. To be more specific, there's certain kinds of expectations that we want to look for. One is the expectations of benefits. So are patients expecting reduction of symptoms? Are they expecting an increase in quality of life? On the other hand, we also want to know about expectations about negative effects or adverse events that patients might expect from a treatment. And the third thing I would recommend is to also ask about previous treatment experiences, since we know that they are a major source of positive and negative expectations of future treatments.
Can you provide an example to us of how you would initiate that conversation with patients?
Sure. So one example could be to ask a question, something like, how much do you think this treatment will help you? And in order to trigger negative expectations, you can ask something like, are you concerned about any negative effects or risks from the treatment you're going to receive?
Okay. Let's go on to the second recommendation, which is strengthen the patient-clinician relationship. You mentioned the importance of warmth and competence. Can you elaborate on that for us?
Sure. So there are several studies that show that a good patient-clinician relationship is associated with better treatment outcomes. Specifically, if patients perceive the clinician as both warm and competent, we do tend to observe better treatment outcomes compared to either patients perceiving the patients as neither warm and competent or just one of the dimension.
So how do you suggest that we project warmth and how do we project competence?
So you can display warmth in many forms. A good start is always to ask open questions and then to listen to what your patient is telling you about the experiences with his or her disease. And you can show verbal signs or non-verbal signs of understanding, like nodding, keeping eye contact, or rephrasing what the patient just said to you. It's a technique that's called reflective listening.
And the competence part, how do we show we're competent? We don't want to come off as sounding arrogant. So how do we sound competent without sounding like a know-it-all?
Yeah, right. I think that's very important to distinguish arrogance from competence. I think many clinicians usually do this in their routine care. So in order to sound competent, you can just show a good structured communication. You can point out the symptoms that the patient just described to you and put them into a context that helps the patient to understand the disease better. And you can also refer to your experience with this disease or treating this disease, possibly also giving an example of a previous patient in a similar condition that had a good treatment trajectory.
Great, thank you. The third recommendation is improve expectations. In the first part of this recommendation, you discuss the data to support the power of positive thinking. Can you describe studies that support this?
Yeah, so there's two very interesting studies, one of which is a study done by Bingham and colleagues. And what they did is to invite participants into their lab and to apply a heat pain stimulus to their arm. In addition, they were hooked up to an IV in order to receive an application of remifentanil, which is a fast-acting analgesic. And each participant went through 4 different conditions. It's important to know that in each condition, the heat pain stimulus remained the same. So the first condition was receiving just the heat pain in order to get a baseline about the painfulness of the stimulus. The second condition was that the analgesic was started, but the patients were not told about receiving the pain medication already. So what they found was some reduction of the pain perception. In the third condition, participants were still receiving remifentanil. However, now the experimenter told them that they were receiving the drug, and they observed a much stronger reduction in pain perception. And in the last condition, they were still receiving the analgesic. However, the experimenter told them that the analgesic was being stopped. And strikingly, they found almost no reduction in pain perception. The levels of pain were almost as high as with the baseline condition. So what that tells us is that communicating that a patient is getting an active drug can have a positive effect, or communicating that they are not getting a drug can have a negative effect about the effectiveness of an active medical treatment.
Does it matter who is communicating that they're getting an effective drug, or is it just that as long as the patient knows they're getting an effective drug?
Well, I think that refers back to a person that you have a good patient-clinician relationship. So if there's someone where you trust in and then you have the feeling that the person that communicates this expectation is competent, I think that has a much stronger impact comparing to, just overhearing it from someone that doesn't have the perception of those dimensions.
Yeah, and the reason I'm asking that is it really depends on the setting. If someone is an outpatient and it's a physician may be giving them the drug directly, but in an inpatient setting, it's often the nurse that is giving the pain medication. And so it's really the person who's right there giving the medication that can help with the positive expectations of what could happen.
Absolutely. I think that is one of the main practical applications is the routine administration of medications in stationary care, to just tell them, well, today or now you're receiving medication XYZ, which is expected to have the following effect. So I think that this is also important for nurses as well as physicians.
And you gave the specific example of pain, which we know has a very individualized and even subjective component. What are some of the other areas besides pain where positive expectations could be particularly helpful when, say, prescribing a medication?
Yes. Another good example is a study done by Faria and colleagues. They recruited patients suffering from social anxiety disorder. And patients were randomized to one of 2 groups. Each of the groups received the same dose of an SSRI as an active treatment for social anxiety disorder. However, one of the group was being told, you're receiving an active medication for social anxiety disorder, and the other group was being told incorrectly, you're receiving an active placebo. And then they followed them up for over 9 weeks of treatment. And what they found was that both conditions improved regarding their social anxiety symptoms, but the improvement was much larger in the group that was correctly being told that they were receiving an active medication. So again, a striking example that labeling the application of an active medication or mislabeling the application of an active medication can make quite a difference in the effectiveness of the medical treatment.
So if I were to kind of summarize that, if we are talking to a patient and we present a particular therapy as this is going to work, it will have positive effects, the patients will be more likely to have benefit. But the converse can happen too, that if we're not particularly enthusiastic about a therapy, it could also diminish the expectations on the patient side of how well they'll do.
Yeah, that's correct. I think the main point is at least tell them that you're administering a medication that is known to be effective in treating this condition.
And one of the things that I wanted to bring up here is that it's a fine line between projecting something as this is going to work and being overly optimistic about it or even potentially manipulative, trying to convince a patient to do something. What do you have to say about that?
Yeah, I think that's a really important point because obviously there's the ethical principle of patient autonomy, which states that you're not supposed to misinform a patient, and stating overly positive expectations might be such a case. And it could be harmful because if those very positive expectations then are violated because the treatment is not going as well as you suggested, this might harm trust in the patient-clinician relationship. And as we already discussed, this is something we would like to avoid. On the other hand, from what we now know about expectation effects, so that not stating positive expectations about the effectiveness of a treatment or even downplaying the expectations with the intention to avoid disappointment might actually reduce treatment effects. And this would be a violation of the ethical principles of beneficence or non-maleficence. So I think you have to balance both ethical principles. And one practical solution that I would give is to just state quite realistic expectations. So expectations that you think that most of the patients might realistically achieve, but frame it in a positive way. So this could mean frame the expectations in a way that is personally meaningful to the patient, or make them specific to the context of their personal life so that the expectation effects are much more potent for this specific individual patient.
Yeah, I agree. We really shouldn't be prescribing therapies that we don't think are going to benefit patients. And if we think it's going to benefit, then it seems like a good idea to explain to them that we think it'll be beneficial. You also mentioned a mental recovery map. Can you describe what that looks like and provide an example?
Sure, yes. That's something that we use to improve patients' expectations in our study with cardiac surgery patients. So what we are trying to do with this personal mental recovery map is to identify expectations that are personally relevant to a specific patient, and then to draw a step-by-step mental recovery map. So maybe I can give you an example of a patient I was able to work with. So let's call her Mrs. S. At the beginning of our session, she told me that the cardiac disease was especially interfering with her personal life in a way that she could no longer go hiking with her friend group, something that was dear to her. So what we did then was to look at recommendations of cardiac surgeons about the reuptake of certain activities following cardiac surgery. And then we developed a step-by-step plan following those recommendations of how she might be able to progress to going hiking with her friend group again. So this could be after 6 weeks, going first walks, couple of weeks later, increasing the distances of the walks, maybe being able to walk certain inclines. And this ultimately led to the expectation that after 6 months, she imagined herself going to her favorite Italian mountain lake and being able to walk from the lakeside to the top of the mountain village and to look down and soak it all in, the sun and the beautiful mountain view. And coincidentally, 4 months later, I received a postcard from this lake, and the expectation obviously was realistic, but also was something that evoked something that was dear to her, positive emotions, and had a motivating force behind it. And that's something that we would try to achieve, activate positive emotions connected to this personally relevant expectation, but also have like a step-by-step guardrail on your way to recovery so that you can, check back, am I on a good path? Because like I was told, we made this plan about this achievement is going to be expected following the treatment, which can reinforce your positive expectations.
Great. Yeah, that ties in really nicely and aligns with the piece that we had earlier in this series on communicating with patients about surgery and thinking about how to frame expectations after surgery in terms of function, not just thinking about complications. And so this really aligns with, before we were talking about treatments like pain management or treatment of social anxiety. It also applies when thinking about surgery. So it's nice to see that aligns with other recommendations that we've been giving. Your final recommendation is manage adverse effect expectations and personal control expectations. Can you describe what you mean by that?
Yes. So from what we talked about earlier, negative expectations or expectations about side effects can actually increase the experience of side effects. But we also know that the way clinicians talk about side effects can moderate this negative expectation effect. So to give you a bad example for start would be the package insert of a medication. So those are normally focused on adverse events, and you will find information such as 10 out of 100 patients will get adverse event XYZ. And usually you don't find a lot of information about the benefits from the treatment of the medication. And there's evidence-based techniques that would do the complete opposite. So one is you should balance the information about side effects with information about the positive expectations you can have from this treatment. So this could be something like, well, taking this medication will reduce your risk of, for example, getting a heart attack, or will reduce your symptoms. But also some patients might experience side effect XYZ. So you have a balance between the negative expectations for side effects with the positive expectations for benefits from the treatment. So patients have a reason to actually take those medications. In addition, something that might also be an effective technique is to frame the symptoms or side effects of a medication as a sign that the treatment is actually doing what it's supposed to do, in order to reinforce the expectation that they are taking an effective or powerful treatment. Another technique would be to frame the frequency statements of adverse events. So usually adverse events or side effects are stated as, 10 out of 100 patients will experience a certain kind of side effect. And there's studies that compared this kind of statement with the opposite statement, saying 90 out of 100 will not experience this certain kind of side effect. And what they found was that patients with a positive frame, which would be 90 out of 100 are not experiencing this side effect, reported less systemic side effects compared to the patients receiving the same frequency information but framed negatively, saying 10 out of 100 will experience this side effect.
Thank you. I think that's useful in terms of how we can frame side effects. I hadn't thought about the package insert that way, but it's really a whole list of negatives and a couple of indications that are the positive, and patients more and more start looking at those. I wanted to go back to the point that you made about saying that sometimes having side effects or symptoms from a medication suggests that it's working. So can you give me an example of how you would say something to a patient about that?
Yes. So, for example, a study tried this with methotrexate. And essentially what they were saying is that these symptoms that you're experiencing can be a good sign that methotrexate is actually actively working in your body and doing what it's supposed to do.
My last question is, do you have any final thoughts?
One final thought is, if a clinician now wants to incorporate expectation management into their clinical routine, I would say a good starting point is to just, ask a patient about expectations or talk about your own expectations of the treatment and take it on from there. This could be a major factor for improving the treatment effectiveness of your treatment.
Great. Thank you so much. I am Dr. Ann Cappola, and I have been speaking with Dr. Johannes Laferton about improving patients' treatment expectations. You can find a link to the article in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.